Hi, this is Arlene Taylor, and today I'm going to be presenting my final capstone. So let's start off with our clinical case. A patient comes in complaining of progressive ataxic gait for 3 months. This is NT, a previously healthy 3-year-old female brought into the ED by her mom for increasing coordination and clumsiness over the past 3 months. She fell last night walking up the stairs. No obvious injuries occurred, but her mom decided to bring her in for evaluation. She has had 3 episodes of vomiting over the past 2 days and a few episodes of urinary incontinence, which is unlike her. She's been sleeping more lately and not feeling well, but denies any headaches, decreased appetite, fevers, chills, or any other associated symptoms. This is her ROS, just including all the things from the HPI that we already knew. So the fatigue, decreased activity, incontinence, vomiting, that ataxic gait, and the mom describes it as a shuffling gait, and then the feeling of sleepiness. The ROS besides that is negative. This was her physical exam. She has some abnormal vital signs of a heart rate of 60, so that's bradycardic. In this age range, it should be about from 80 to 120 beats per minute, and her respiratory rate was also 18, and typically it should be 20 to 28, so she also has a little bit of bradypnea. Whenever a patient comes in with a neurological complaint, it's important to get a full neurological exam. This includes mental status, cranial nerves, motor, deep tendon reflexes, sensation, and coordination. So on this patient, everything was negative except for her coordination. She was unable to walk more than 5 feet without having that unsteady kind of gait, shuffling, and leaning forward. A CT scan was obtained of her head showing those enlarged ventricles or hydrocephalus secondary to a mass. As for her assessment and plan, she was diagnosed with obstructive hydrocephalus secondary to a mass, and for the case of this presentation, I want to just focus on the fact that she needed a VP shunt insertion, which I will explain more in a little bit. So on the previous slide, I talked about hydrocephalus and being that accumulation of the fluid. The fluid that we're talking about is cerebrospinal fluid, or CSF. This is composed of 99% water, and then the remainder 1% is a mixture of ions, proteins, and neurotransmitters. CSF has many functions, such as being a protective cushion for the brain and spinal cord, filtering out waste products, providing nutrients to the brain, and proteins, and then also helping to maintain that biochemical homeostasis in the central nervous system. To the right, I have just a very basic overview of the ventricular system, so you could kind of picture it in your head how it's working and how it connects together. I did want to go over the normal flow of CSF. It starts by being produced in the choroid plexus. Then it flows into the lateral ventricles, through the foramen of Monroe, and into that third ventricle. Then it'll go through the aqueduct of Sylvius and into the fourth ventricle. Next, it'll flow either laterally through the foramen of Luschka or medially through the foramen of Magendie into that subarachnoid space, and then will be reabsorbed into the outpouchings into the superior sagittal sinus. And finally, eventually, CSF will be reabsorbed into the bloodstream via a pressure-dependent gradient. So hydrocephalus itself is an accumulation of that CSF in the ventricles or the subarachnoid space. So what happens is you have this accumulation of fluid that pushes out against the brain, causing that increased intracranial pressure, or ICP, and that ventricular dilation we saw in that CT scan. When this occurs, you have that compression of the brain and spinal cord that could lead to permanent damage. And then there's just an image to the right that shows how that accumulation of fluid is pushing up against the brain. So this is a pretty common disorder, and it affects 1 to 2 out of every 1,000 infants at birth. It can be inherited or secondary to other conditions, such as brain tumors like our patient in the beginning, head trauma, hemorrhaging or bleeding, or meningitis. It can be classified into 5 different categories. So you have acquired, congenital, communicating, which is where there's a blockage in that after the ventricular system, so you're able to still have that communicating back and forth between the ventricles. Obstructive, which is where you have some kind of blockage in the ventricular system, and then normal pressure hydrocephalus, and that usually happens in the elderly most often, and those are the buzzwords that you hear, that wet, whacking, wild. Signs and symptoms are typically kind of categorized between the age less than 2 and greater than 2, but they can kind of run back and forth. Less than 2 years old, the most common sign you'll see is progressive macrocephaly, so the head enlargement, and the bulging fontanelle, so that soft spot up there will be bulging or tense. You can also have parents who report vomiting, lethargy, irritability, and seizures in their infants or their children under 2. Children over 2 years old typically present with symptoms more consistent with intracranial hypertension. So they'll present with things like headache, irritability, nausea, vomiting, lethargy. They can also have things like decreased appetite, double vision, and some others that are listed there, like the urinary incontinence that we saw in our patient. I like the Cushing's triad, and this is kind of a marker that could tell if you have acute increased intracranial pressure or ICP, and this consists of respiratory depression, bradycardia, and wide impulse pressure, so an increase in the systolic pressure and a decrease in the diastolic pressure. We did see in our patient that she had the bradycardia and respiratory depression, suggesting that increased ICP. I also have a picture of an MRI with normal ventricle size and then those enlarged ventricle size, so you can just see how massive it is pushing up against the brain. The first thing you need to do to diagnose hydrocephalus is take a good history and physical exam, and then if there's any suspicion whatsoever of increased ICP or hydrocephalus symptoms, you need cerebral imaging like ultrasound, a CT scan, or an MRI. And again, to the right is just another image just illustrating normal ventricle size and then dilation of both ventricles, or just having one ventricle that is dilated. As far as treatment goes, early intervention is going to be very critical to avoid bad outcomes like brain herniation. You're going to need ultimately to insert a shunt. And to the right, there's a VP or ventriculoperitoneal shunt, which we will be talking about more in the next couple slides. And this is, again, to provide an alternative route of the CSF from the accumulation in the ventricles to a different body cavity. So the next question I had was, is this relevant? And the answer I found is yes. So shunt placements secondary to hydrocephalus are the most common procedures performed by pediatric neurosurgeons and unfortunately have the highest failure rate. I did include a couple facts below just to hit that point home a little bit more, showing just how many shunt insertions there are annually, the hospital admissions, hospital days, and then on average how much hospitals are paying for these shunt insertions. So this is just to show you how significant of an effect this is having on patients' health, their finances, and then a substantial amount of hospital resources is being spent on this as well. So shunts themselves are these hollow flexible tubes that are used to divert that excess CSF into whatever body cavity depending on the shunt type. If you look in the lower left-hand corner, this is what one looks like. So you have that ventricular, the proximal catheter that's placed into the ventricles, and then it connects to a shunt valve, which will actually control that flow rate of how much CSF is being diverted out of the ventricles. And then this connects to that distal or outflow catheter, which drains into the body cavity chosen. We're going to be focusing on the ventriculoperitoneal or VP shunts, and this takes that excess CSF and diverts it into the peritoneal cavity or the abdomen. This is the most commonly used. It has easy accessibility and it allows for a larger surface area, so it has increased CSF absorption. And then to the upper left, you can also see a picture of pre-op and then post-op, just how effective the shunts are at diverting that CSF. So shunt failure itself is when the CSF is no longer being diverted away from the brain. So it'll lead to that reaccumulation of CSF, the increased ICP, and the return of all your symptoms. And these symptoms can vary very widely from anywhere from a mild headache to death. And shunt failures can be caused by several things, such as obstruction, so a blockage in that shunt tubing, intracranial hemorrhage or a bleed, overdrainage, where the CSF is being pulled quicker than it's being produced, so it can actually tear away the brain and the meninges from the skull, and then also infection, which is where our focus is going to be on today. Treatment's guided based on etiology, but ultimately you're gonna end up with surgical intervention for either revision of the shunt or reinsertion of the shunt. So not only are shunts the most common pediatric neurosurgical procedure and also the most failure prone, but in general, they're the most failure prone, life-sustaining medical device implanted in modern medical practice, according to this study by Hennick et al. This study also found that in general, the failure rate at 1 year post-op is 30 to 40% and actually spikes up to approximately 50% at 2 years. And this was focused on children 1 to 7 years old. And this was shunt failure in general. So it includes all the etiologies, not just the one that we're going to focus on, which is infection. So we're going to be focusing on shunt infections. This is most prominent in the early post-op period. So 90% occur within the first 6 months. One article I looked at compared shunt failures between the first month and 2 years and looked at the different etiologies, and it showed that 45% at that first month were secondary to infection versus only 6% were secondary to infection at 2 years. So again, this gives further validation that this is that shunt infections is mostly an acute post-op complication. I also wanted to focus on that pediatric population, and there is a statistic that says that the rates in pediatric patients is roughly 20% compared with 1.6 to 16.7% in adults, and that's the infection rate. So this is more likely to occur in the pediatric population, so that is where I focus this research on. So the primary source of infection is common skin flora, and this happens via the proximal catheter, perioperatively during surgical shunt insertion, and then postoperatively due to wound infection. And these are most commonly caused by gram-positive bacteria in the acute infection phase, with coagulus negative staphylococci and cons, and these are type of staph bacteria that's commonly found on a person's skin, and in normal circumstances they're completely harmless, but then when they aggregate together against the bloodstream is when we see infections occur. So specifically we see Staphylococcus epidermidis in 60% of the cases, and then we also see Staphylococcus aureus in 1/5 of the cases. Later infections are typically associated with streptococci or enterococci species, and then you also have gram-negative bacteria, specifically Pseudomonas aeruginosa, that is seen with VP shunts complications such as the peritonitis and bowel perforation. So the types of signs and symptoms that patients with shunt infections have vary depending on the type of shunts. So they can have just general signs of infections like fevers, redness, pus, and swelling at that incision site, or you can have with specifically with the VP shunts that we're going to be talking about, you can have things like a severe abdominal pain, anorexia, decreased appetite, and then some peritonitis. If you do suspect a shunt infection, though, it is critical to get shunt series, which is our full X-ray imaging, AP and lateral of the entire shunt system. You also want to get CSF analysis and blood cultures and imaging. Risk factors to get shunt infections include being younger age, again, that pediatric age range, history of neurosurgery or shunt revisions, and gastrostomy tubes. Some complications from untreated shunt infections obviously would include death. You can also have things like sepsis, meningitis, cognitive impairments, and then prolonged hospital stays and expenses. The specific treatment of shunt infections is variable depending on the site you're at, but it's pretty consistent that you need emergent removal of the shunts and then EVD or external ventricular drain place, which is where they take the CSF from the ventricles and it gets drained or diverted out into an external system, which is pictured to the right there. So it's adjustable. It's based on the head of the bed and gravity. You also need cultures, that intraventricular, intravenous antibiotics, and typically it's like meningitis where you want to start empirical therapy before even the cultures come back. So typically they'll start vancomycin and a third generation cephalosporin to cover for both gram-negative and gram-positives. And then when they're going to have the shunt reinsertion or revision is also variable. I did find a good study that said that it's best to do this when there's 3 negative cultures and the patient has been fever-free for 24 hours. And even with perioperative antibiotics being mostly a standard of care, infection rate is still high. So my main question is, can these shunt infections and shunt failure be prevented? So when doing research into preventing VP shunt infections, I came across antibiotic impregnated catheters, or AIC, and these have both the inner and outer lumen surfaces saturated with antibiotics, and this helps to provide a steady release of antimicrobial activity for up to 50 days. So again, that acute post-op period where we see the majority of infections happening. And this works by preventing that colonization of bacteria during that surgical implantation, And typically they tend to use rifampin and clindamycin together. Sometimes they'll use minocycline instead of the clindamycin. The rifampin's used because it is highly active against the cons, specifically that Staphylococcus epidermidis. Clindamycin's also added because it's active against majority of the cons, and then also there's been rapid resistance seen with just rifampin as monotherapy. To the right, there's just a picture showing standard catheters or SCs versus antibiotic catheters and AICs, and just how they work by releasing steadily that antimicrobial activity. So we see NT comes back into the ED 1 month post-op of that VP shunt insertion. She presents with a fever, vomiting, and worsening abdominal pain over the past 2 days. What are we thinking? Well, we should be thinking, oh no, it's a shunt infection. Let's get our CSF analysis, cultures, shunt studies, imaging, and unfortunately, we see that a shunt infection was confirmed. So first thing we need to do is we remove the shunt, hook her up to an EVD, get some empirical IV antibiotics, and then we have to reinsert that shunt infection. So we see that in 2 months, she has gotten 2 pretty serious neurosurgical procedures already. So taking what we've been talking about and putting it all together, I came up with a focused research question. Ventriculoperitoneal or VP shunt infections. Is using antibiotic impregnated catheters or AICs an effective way to decrease its occurrences in the pediatric population? So this was my methodology. It was a systematic review of literature. I included 8 articles for reviewing using PubMed and Medline as my research databases, and then these medical subject headings or mesh titles such as ventricular VP shunt complications, followed by the rest that is written there. They had to be within the past 15 years and peer-reviewed, and then they had to have some other criteria such as including different catheter types like standard catheters or SCs, silver-coated catheters or SCCs, and hydrogel-coated catheters, HCCs, to get a comparison on the effectiveness of all of them. The first study I looked at was a retrospective study by Sawara et al. That reviewed 123 pediatric patients from May 2004 to December 2010. It included a total of 211 VP shunt insertions, 193 of which were standard catheters or SCs, and 18 were AICs. They evaluated for any signs of infections for up to 26.2 months or around 2 years. They did find some statistical significant results, of which 0 patients or 0% of patients with AICs had any signs of infection versus 12 patients or 6% that had the SCs did have signs of infections. However, this did not look at long-term follow-up. Again, it focused on those first 26.2 months. So this does suggest that AICs are effective in decreasing the infection rate. This next study I looked at was larger. It was a systematic review and meta-analysis by Constellius et al. This looked at 36 studies and 16,796 total shunt insertions. So it's a lot more than the previous article looked at. And this also compared AICs versus SCs versus AICs. So it's looking at the effectiveness of all the different types of antimicrobial shunts. It did find statistically significant results in that both the AICs and SCCs do decrease that risk of infection compared to HCCs. So interestingly, though, it did find that with the SCCs and the AICs, there was also increased risk of MRSA or methicillin-resistant staphylococcus, non-staphylococcal, and gram-negative bacterial infections. So it might be helping to decrease the overall rate of infections, but those infections that are seen with AICs and SCCs are more likely to be more virulent infections. So this next study was a randomized controlled trial, or RCT, by Malucci et al. And this looked at a total of 1,594 patients and compared the efficacy of standard catheters, or SCs, SCCs, and AICs, and those were distributed evenly. So this did not use HCCs at all. Patients were followed then for infection signs for a minimum of 6 months and a maximum of 2 years. They did find statistically significant results showing that the use of AICs decreased the infection rate, but SCCs and SCs did not. So this is different than the previous study that found that both AICs and SCCs did decrease the infection rate. So all three of the studies looked at so far did see the decrease in the infection rate with AICs, but not all of them saw the decrease of infection rate with the SCCs, which was interesting. Next, we have another systematic review and meta-analysis by Klimo et al. That looked at 6 studies with a total of 3,474 VP shunt insertions. Out of those, 2,396 were SCs and 1,078 of them were AICs. This did have statistically significant results indicating that infections were almost 2 times more likely to occur with SCs versus AICs. So again, this does show statistically significant evidence that AICs help to decrease that rate of infection with the VP shunts. However, they did have recommendations from one being like very solid and a clear degree of clinical certainty versus 1, 2, 3, and it went up to 5, and this was a level 3 recommendation, so meaning that it was unclear degree of clinical certainty. So although this is a pretty powerful statement and it was statistically significant that infections being 2 times more likely to happen with the standard catheters, I think that it would benefit from some higher level recommendations. So 4 out of the 4 studies that looked at so far showed statistically significant results suggesting that AICs are effective in decreasing the rate of infections with VP shunts. So going from there, I wanted to answer a couple other questions, such as, does the route of the antibiotic administration matter? How about if there's a combination of them? And then how about specific risk factors and patient demographics? I also wanted to look at other bacterial coverage. So we know already that AICs seem to be effective in these common skin flora bacteria like the Staphylococcus epidermidis and Staphylococcus aureus. How about other infections that are seen just not as common as those two? So this first study looked at was to kind of answer that first question about the route of the antibiotics and if that matters. This was a systematic review of literature by Arts et al. Looking at 11 RCTs with 1,109 patients, and it compared different routes including orally, IV, intrathecally, topically, and with the AICs. Unfortunately, results were inconclusive due to quality and sample size. However, in general, there was a consensus that antibiotics prophylaxis seems to have an impact on decreasing the rate of shunt infections no matter what the route is. So in general, antibiotics will help to decrease that rate of infection. So this retrospective cohort study by Jaeger et al. Looked at 2 different kind of protocols. They looked at standardized catheters or SCs that were used from February 2002 to April 2007 in 24 neonates and compared it to a new protocol that was implemented with the use of AICs and perioperative antibiotics. And this was from August 2007 to July 2015 and included 23 neonates. So this was a smaller study. But again, this looks at the difference, the route of administration, and putting these antibiotics together and seeing if there's any difference in the efficacy. It did find statistically significant results that the median time interval actually from surgery to shunt infection was lengthened in those that got the AICs and perioperative antibiotics. So the average day of getting the shunt infection was 148 days when the new protocol was used versus the time of shunt insertion to shunt infection was on average 48 days in the patients who just received the SCs. So this does show promise that used together, it can be more effective in preventing those acute post-op period infections. It did show a decrease in infections in the 2 from 20.8% to 8.7% in general, but it wasn't statistically significant. This next study is where I wanted to explore if the certain risk factors or patient demographics such as age and sex mattered at all for when you have AICs versus SCs, and who was more likely to get shunt infections and where this is seen more. This is an observational study by Ritz et al. That looked at 258 patients over the course of 24 months. It did show statistically significant results that if you had a past shunt infection, you were at an increased or higher risk for subsequent shunt infections. So this does suggest that the patients who get AICs, it might be able to be more individualized based on risk factors and patient demographics. This is definitely something that could be looked into more, a kind of a risk versus benefit. So the last study that I looked at in this section looked at a different kind of organism besides that typical Staph aureus or Staph epidermidis that we were talking about previously. It looked at something called Propionibacterium or P. acnes. This was an experimental study by Baston et al. So P. acnes itself is an anaerobic skin bacteria, and it accounts for up to 14% of shunt infections. And the main goal of this, or main goals of this experiment, was to, one, evaluate the efficacy of preventing colonization to the surface of the catheter, so see how effective it is at preventing any of those aggregation of bacteria and the subsequent infections. And it also was, a goal was to determine the duration of activity and evaluate for any resistance. So these were done with an in vitro challenge using 3 clinical isolates of P. acnes, and then also through a serial plate transfer test, or SPTT. It did find statistically significant results that all 3 of the P. acnes strains were killed within 96 hours using AICs, and there was no regrowth of that bacteria. It also found that this activity of the antimicrobial activity lasted up to 70 days with no development of any resistance. So this is very promising in that these AICs will also be effective against other, not as common, but still prevalent organisms that are seen typically with these VP shunt infections. And it shows that there has been no regrowth and no resistance, which is a good thing. So these AICs are effective in preventing colonization and preventing any resistance, so effectively killing them. So really quickly, just to recap on our results, we did find that majority of the studies we looked at found statistically significant evidence that AICs are effective in decreasing the acute post-op period rate of VP shunt infections. We also found that there might be some promise in combining AICs and other antibiotic routes. And then we also found that it might be something to look into using AICs on an individual basis, so accounting for specific risk factors, patient demographics, and patient histories. And then we also found that AICs are effective with other organisms, including P. acnes, which are seen in 14% of shunt infections. And these are just an outline of the discussion topics that I'm going to be talking about, starting off with the possibility that AICs can cause an increased risk of the more virulent bacteria. So in general, how we see that increased risk of the more virulent bacteria with our AICs and maybe with our SCCs, this might just be simply secondary to lack of susceptibility with our typical antibiotics used, such as that rifampin, minocycline, and clindamycin. I did look at a prospective observational study by Demetriadis et al., and they found that their overall infection rate using AICs was only 3.2%. However, 100% of those infections with the AICs were rifampin-resistant Staph epidermidis. So generally, rifampin is used to cover strains of MRSA that are resistant to vancomycin. So this is very, very, very important that we can potentially have these resistant and rare bacterial strains that can occur with the overuse of rifampin and can lead to some dangerous and treatment-resistant VP shunt infections. So this is something that definitely needs to be researched more to prevent these resistant VP shunt infections if we do decide to implement AICs as a standard of care. So these are the other antimicrobial catheters that were talked about a little bit in our results sections that were compared with the AICs. SCCs are a combination of insoluble silver, salt, and metallic silver, while HCCs are hydrophilic surfaces that inhibit bacterial adherence. In my research, I couldn't really find any studies that were specifically on HCCs and SCCs that didn't also include AICs. They were just mostly used to kind of compare the efficacy. And like I said, only that one study by the Constellius et al. Showed any promise that SCCs can be used just as effectively as AICs to decrease the risk of infection. When I had my question of if there was any difference with revision and reinsertion, and we already know that if you've had a previous shunt infection, you're more likely to have a subsequent shunt infection. So I did want to look at if it mattered what kind of shunt catheter system was being placed. So this study was really good and I felt pretty powerful. It was by James et al. And what they did is they looked at 3 different subgroups. The subgroup 1 was when they had primary AIC insertion. So this was their de novo first time shunt insertion, was with the antibiotic impregnated catheter. The second subgroup looked at when you had a non-AIC, so something like a standard catheter, and then it was replaced with an AIC. And then the third subgroup look at when there was a revision of a previous AIC with a subsequent AIC. And interestingly, the infection rate from that primary insertion was only 1.6% compared to the infection rate of 11.7% when you had already a previous AIC and a revision with another subsequent AIC. As far as not as having just a regular standard catheter, an SC, and having it be revised with an AIC, the infection rate was only 2.5%. So you see this drastic increase of infection when you already had an AIC and you get something happens where it fails and then you replace it with another AIC, you're more likely to have that fail, to have a shunt infection. So that was really interesting to me to help to point out that again, having an AIC should be something that's individualized patient to patient based on demographics and risk factors, and having a de novo insertion of an AIC is something that it should be implemented versus maybe a revision should be thought of more on a case-by-case basis. It also just included some more common organisms seen in SCs versus AICs. Again, you see at that top those coagulase negative Staphylococcus and the Staph aureus as being in the top for the standard catheters, and then Staph aureus being in the top for AICs versus. Something also really important to keep in mind is if it is cost effective or not. In the United States, shunt infections are actually the highest costing implant related infections to treat. So it's the most common pediatric neurosurgery, it's the highest failure rate, and it's also the highest costing, which is super important. It costs on average $50,000 to treat in the hospitals. So I did want to support this with a study to look into if it actually was cost effective, and I did find a retrospective study by Tenelo et al. That looked at a time period from April 2001 to December 2006. Before October 2002, patients were given SCs compared to after October 2002, they were given AICs. It did have statistically significant results in both that it was cost effective and that there was a decrease in shunt infections with the use of AICs. So 25 patients, or 12%, with SCs had shunt infections, and this ended up costing hospitals $1,234,928 to treat, versus 13 patients, or 3.2%, with AICs had shunt infections, and this costed hospitals $606,328 to treat. So you can see just how significantly more SCs are costing to treat, because there are more infections that are seen with using these types of catheters. They also found that infection-related hospital costs per 100 patients undergoing the shunt insertions was $151,582 for those patients who received the AICs, versus $593,715 for those patients who were receiving the SCs. So we do see that this is very cost-effective using AICs versus SCs. So the study was not without limitations. Some limitations of the study itself is that not all of them focus on the pediatric population, different qualifications for what they consider a shunt infection, and then some variability in surgical technique and neurosurgeon expertise. Also, some personal limitations was personal bias, time constraints being one researcher, and lack of funding. So throughout the results and the discussions, I feel like I did talk about some future considerations that need to be just kind of thought about and investigated more. I also did want to point out, again, for like the 5th time, because I think it's very important, that there should be some thought on individualizing treatment plans, evaluating for specific risk factors and demographics and different variables, whether or not AIC should be the right call or the next call versus standardized catheters or other antimicrobial shunts. And I also wanted to just look into, or I think it would be important to look into, what can be done besides these antimicrobial shunts. I know we looked at different routes of antibiotic administration, but specifically some protocols, just stricter protocols in the operating room or the OR. Maybe some stricter checklists, surgical checklists, to make sure that you're going through step by step to avoid introducing any bacteria in that perioperative or postoperative period, that diminishing it or reducing it as much as you personally can, or we personally can. I also think it would be beneficial to look at some topical antibiotic usage. We did look at that study that looked at some oral, IV, intrathecally, and AICs as the route of administration, but topically while in surgery, I think would be interesting to look at as well. So before wrapping up, I did look into a couple of where those future considerations I think should go. I did myself do some research into them. I found this retrospective cohort study by Linder et al. That looked at the use of strict shunt protocols and the addition of that intraoperative vancomycin, so that would be that topical antibiotics. What they did is they just used strict protocols, like some strict OR planning and room regulation, so limiting amount of people coming back and forth or doors opening and closing, using electric razors in patient preparation, double gloving in surgery, avoiding bandage change within 24 hours. So just some strict protocols that they make sure to follow. So again, it did look at that intraoperative vancomycin, and vancomycin is effective against gram-positive cocci and bacilli, including those Staph epidermidis and Staph aureus, those two most common organisms we see. So a solution, a 2 milligram to milliliter solution, was created. The surgical site is flushed superficially. The solution was applied to the surgical gloves, the operative gauze, and used to superficially flush the shunt and fill that shunt reservoir. So basically this solution is being utilized in the entire intraoperative period to make sure that as much of it is directly administered to the site. It did find statistically significant results showing that the rate of infection decreased from 6.8% to 3%. So this is a pretty promising future direction to use. And as an added benefit, the cost of it is more cost effective than AICs. AICs cost roughly $400 for each surgery, while the addition of that topical vancomycins only costs about roughly $10. And then the last study I just wanted to look into was, again, using a surgical checklist. And this was a study by Lee et al. That looked at the prior years, 4 years prior to a surgical checklist implementation versus 4 years after that checklist was implemented. It did find statistically significant results, suggesting that showing that the infection rate did decrease from 3.03% to 1.01%. So this surgical checklist would be things like making sure that everyone had their all their PPE on, everyone washed their hands, was double gloved, some of the same things as the protocols in the previous study. So at this point, I just wanted to kind of circle back and again focus in on this research question that I had in the beginning. So VP shunt infections, is using AICs an effective way to decrease these occurrences in the pediatric population? Now, from the results sections and the discussions and everything we've been talking about for the past almost hour, I think that this question has been answered pretty effectively. And again, I'm hoping that by just watching and listening to this PowerPoint, you're able to come to the same conclusion that I have with doing all my research, that overall the data suggests that AICs are life-saving, they're cost-saving, and they should be implemented in all pediatric patients, especially those receiving VP shunts for the first time, to prevent surgical outcomes, reduce the occurrence of shunt failure, and subsequent neurosurgical procedures and extra hospital stays. Unfortunately, the diagnosis of hydrocephalus isn't going anywhere. There are always going to be pediatric patients needing shunt placements, and I think we owe it to our patients and their families to figure out the best ways to decrease these shunts from failing, no matter what the cause. Please email me with any questions, and thank you so much for listening.